Hello, everybody. I'm Sara Marberry, and this is my presentation, In the Wake of COVID-19, What's Next for Healthcare Planning and Design? Before I begin, though, I just want to give you a little bit of the backstory about how I got into healthcare design. Because I'm not a designer, I'm not an architect, I actually studied communication and journalism in college. And when I was working for Contract Magazine in 1987, I met a man at an event at the San Francisco Furniture Mart named Wayne Ruga. And Wayne was a healthcare architect who told me he was going to start a healthcare interior design symposium. And so, like every editor does, I said, well, just send me information about it. And so not only did Wayne send me information about this symposium, he asked me to join its advisory board, and then he asked me to be its first MC. And so meeting Wayne began what has become a 32-year journey for me of working in the healthcare design industry. And my healthcare design education actually was editing 8 volumes of the Journal of Healthcare Design. These were the edited transcripts of every presentation that was given at the symposium. So in essence, I relived the whole conference every year by going over these transcripts and editing them into these journals. So it was an incredible design education, healthcare design education that I was given, and I'm so grateful for it. In this presentation, though, I am not going to talk about how the U.S. healthcare system is currently dealing with the facilities challenges presented by COVID-19. Rather, I'm going to share what I think the pandemic's impact on the healthcare facility planning and design will be in the near future and beyond. Because, like this cover of Modern Healthcare says, clearly we are not ready. You may have seen this map, and this was done last month. Well, actually, I'm speaking to you, it's now April, but this was an analysis done by Array Advisors in March that suggested that even if hospitals were to cancel all elective surgeries, there would be no available beds in intensive care units in the US by the end of April, and beds in medical surgical units would reach full capacity by mid-May. Now, as I'm speaking to you, it is now mid-April, and the virus, the pandemic is starting to flatten in some states. So we may not have reached the projections of this model because we've been able to slow the spread of the virus by staying home. But our hospital system is still strained. So clearly we are not ready for a pandemic like this. Why not? Well, one of the reasons is that hospitals are built to run lean. And that means even if they have to board sick patients in corridors during peak flu season. And the reality is, over the past decade, the healthcare industry has been focused on shrinking hospital bed capacity, moving the care to the home or hospices or other outpatient settings. And cost cutting and cost effectiveness have been a priority for healthcare providers. And that's what they've been asking of their planners and designers to address, not emergency preparedness. The other thing is that old hospitals are usually torn down. Some are repurposed, yes, but most of them, many of them actually, are demolished. And the reality is also that infectious disease departments are underfunded and poorly staffed. And this is despite recent past experiences with SARS and Ebola. And this exists on both a local level and a national level. And in fact, before COVID-19 became such a global problem, the Trump administration had proposed a 2020 budget for the Department of Health and Human Services, and it had cut $25 million from the Office of Public Health Preparedness and Response. Excuse me. And it had also cut another $18 million from the Hospital Preparedness Program, whose purpose is to help hospitals prepare for emergency surges of patients. And this program was already under-equipped to handle situations like COVID-19. So the funding on the national level just hasn't been there. And so that definitely trickles down to the local level. There also isn't a good plan in place for nurse shortages during crises, any kind of crises. And in some cases, nurses who fill the gaps are retired, or they're semi-retired nurses whose older age puts them at higher risk for coming down with COVID-19. So that's a problem. And also, as many of us in the design industry are well aware, that our healthcare facilities aren't designed for social distancing. Patients and staff and family members are often very close to each other during times of extreme illness. None of this can be the model for tomorrow's resilient healthcare system. But wait, I think there is some good news. And part of the good news is that hospitals are among the most highly regulated building types, especially when it comes to safety and infection control. And many hospitals have been specifically designed to care for patients with infectious diseases without, spreading viruses or bacteria. Hospital operations are also heavily influenced by these precautions, especially as it relates to hand washing and contact and isolation. But what's happened with COVID-19 will compel many hospitals to revisit best practices for design. My friend, healthcare architect Sheila Kahneman, asks a really good question. Can COVID-19 spur a rethinking of processes and healthcare settings, boosting new ideas that are just beginning to take hold and reinvigorating best practices? And I think the answer to that question is yes. And that's the other good news. So what happens after we flatten the curve and the outbreak subsides? How can healthcare providers, planners, architects, interior designers, and product manufacturers respond so that we're better prepared for this in the future? Well, here's what I think. And it's not just my opinion. I've been reading a lot of articles by various folks over the last couple weeks, 2 or 3 weeks. By the way, most of them are referenced at the end of this presentation. So I'm just going to put forth a few ideas for thought, and hopefully it will spur some of your thinking. So the first thing is that I think it's going to cause us to refocus on flexibility and planning for surge capacity. We already have a lot of models for this, but one in particular is right here in my hometown of Chicago. Rush University's Medical Center Hospital Tower was specifically designed to provide treatment for an outbreak of infectious disease. And here are some of its features. The all-important negative pressure rooms, and then some really interesting things around the ED, in terms of dividing it into, different units and, entry bays that can be configured for isolation, and, also, and ED being able to be converted for screening. And in an article I read recently, they also have the capacity to convert a wing of the hospital into negative pressure unit within only a matter of hours. And you may have seen this concept from the University of Kansas Institute for Health and Wellness Design. This was done a few years ago for I think it was some kind of design competition that was sponsored by Healthcare Design Magazine. But in this proposal, they redesigned patient arrivals by reconfiguring the traditional ambulance. The solution involved two components: a chassis, which they called a ambulance, and interchangeable containers, which are attached to the chassis based on the need of the individual run. And then upon arrival to the ED, the container is detached from the chassis, and it can expand to function as a standard emergency care space, providing care in a sort of a protected environment until the patient can be moved safely. And then when not in use, these containers could be warehoused at an individual emergency department or as part of a regional care system. So there's a lot more to this model, but this is you kind of get the idea for this. And I also think that modular construction might be able to be useful for planning for surge capacity. This is a med modular patient room that already has antimicrobial surfaces and automatic sliding doors and some other features that are good for infection control and prevention. In general, though, as I understand it, modular construction makes more economic sense for larger hospital projects. So I'm not sure it would be useful in like a smaller ED type situation. But it is something that larger hospitals might want to consider in terms of, if they are designing, and I'm sure something like this could also be designed as a negative pressure room as well. Or if it isn't, they're probably trying to figure out how to do it. The second thing I think that the design industry is going to focus on is this idea of rethinking waiting spaces. As I said before, very few healthcare facilities are designed for social distancing. People waiting side by side is a big part of what happens in hospital EDs and ambulatory care centers and outpatient clinics and doctor and dental offices. It's what we do. And hospitals like the University of Chicago Center for Care and Discovery may already have waiting spaces that could accommodate social distancing. In fact, here, it might be just a matter of reconfiguring the furniture arrangements or using this enclosed space that you see in this particular photo that is kind of more intended for VIP type people. It could also be used for someone who might be a little more infected or already been diagnosed with the virus or something like that. But this is actually its 7th floor sky lobby, and but this hospital actually has 102,000 square foot floor plate. So it's a huge space, and not every hospital has this kind of space in its main lobby. And certainly, smaller waiting spaces face different kinds of design challenge. I think the ED in particular is ripe for design innovation when it comes to waiting. And some design innovation is happening, things like waiting nooks and these waiting pods that HKS Architects designed for Northwestern Memorial Hospital in Chicago. These are really good ideas, and they need to be explored and expanded more. The other thing that I think we need to start thinking about, and people have been talking about, is the use of technology. Technology is evolving every day, but there's a lot of cool things out there on the market that could be better utilized or utilized more. Many hospitals are already using UVA technology to disinfect rooms by using mobile units like this. Or installing fixed UV lights in the ceiling, like this hospital in Canada did. But this technology, this UV technology, and all the different ways to disperse it or whatever, make it work, is still evolving. And how about using more automation? Things like touchless automatic doors, voice-activated elevators, hands-free light switches, hands-free temperature controls, or even self-cleaning public bathrooms. Has anybody ever used one of these? I actually did when I was in Paris a couple of years ago. It was kind of cool. We were at the Eiffel Tower, and I really had to go to the bathroom, and this was the option. And I didn't really know what it was, but I went up there and used the toilet, and then when I came out, I could hear it go whoosh, completely disinfected itself. So, and I know cities in the US have this too now. So we have all this technology already. It's just a matter of putting it in, our healthcare facilities or any type of facility for that matter, and making the decision to pay for this technology as opposed to something else, which I'm also going to talk about a little bit later. And here's another concept I think is really important that the design community and the healthcare community needs to embrace and advocate for well building standards. And as you may know, the well building standard is a performance-based system that combines best practices in design and construction with evidence-based scientific research, including performance measurement. And this is their 10 concepts that, they're not all design concepts, but certainly the design of the physical environment supports almost all of these, if not all of them. And this was a program that it took 7 years of rigorous research and development, working with leading scientists and physicians and industry professionals to establish the standard. And it's something that is still being worked on and revised continuously. Menno Haven Rehab Center in Chambersburg, Pennsylvania is the first skilled nursing facility in the world to achieve Gold WELL certification by the International Well Building Institute. And I actually think it's probably also the only healthcare facility in the US to hold this distinction, because the well building program has been mostly focused on offices rather than other types of commercial facilities. But I think more hospitals and healthcare facilities are going to be embracing this as a concept. And as I understand it, the architect was the one that brought this concept to Menno Haven and suggested that the owner do it. And the owner now feels that it's a way of attracting people, not only providing the patients that come there and stay for these short stay rehab situations, but also for the staff and also as a marketing incentive. So these are some of the project features that help Menno Haven achieve WELL certified gold. And now that COVID-19 has happened, I really wouldn't be surprised if the well building standard isn't revised to include more infection control prevention measures. In fact, it's already formed a COVID-19 task force to talk about the role that buildings and communities and organizations can play to support our health and well-being, and also our collective ability to prepare for and respond to global health challenges like the one we're experiencing now. And anybody is invited to join this task force and make your voice heard, or your work, try to contribute your work to this effort. And the company that brought us the well building standard also invented the Stay Well concept. Has anybody heard of this? This was developed by Delos, and Stay Well is a program for hotel rooms that helps maximize the guest experience and minimize the impact that travel has on the human body. So features in a room would be an air purifier, like shown here, that would produce fresher air, and there's personalized lighting features, and this UV wand, which is used by staff to disinfect surfaces in the room before and after guests leave. A few weeks ago, Delos created a facilities improvement program for senior living that draws from a subset of the Stay Well program features. It includes the air purification unit, the UV wand, and then some educational and informational resources. And the great thing about this is that there's no capital outlay required from the senior living operator or owner. It's a license fee, which is about $20 a room per month. So and it includes all these things like filter replacements and programming and so forth, and training for the staff. Now, I have an 86-year-old father who is in an independent living building in a senior living community in Central Illinois. And when I saw that wand and saw all the things that you have to do with it, like you have to hold it over the surface for a set amount of time, and it's very precise in how it works. And I wasn't sure that he actually would be able to use this wand, but I think the idea is, and even though he's very techie, I shouldn't disparage my father, but I feel like that the better use of this is to train the staff in the senior living community to be able to use the wand, just like in the hotel room. But it could also be used by the residents if they are techie enough. And the other thing is, I think about this particular program is I think a similar program could be offered to hospitals and other healthcare facilities. So, there again, this is a creative way to pivot a product and fill a need in the marketplace. And I think we're going to see more things like this come along. Number 5 on my list is to really start thinking about using safer surface materials. And I think the design community, again, this goes back to Sheila's quote about, reinvigorate best practices. Well, safe surface material is a safe, a good practice. But I think, it's a matter of looking at this through a new lens. And we've been talking about things like copper and glass for a while, but let's refocus our efforts on some of these materials. This is a product called Covero, and it's a copper product that, when regularly cleaned, it continuously kills 99% of harmful bacteria. So it's also tarnish resistant, and it won't oxidize like pure copper. And it has a lot of applications in healthcare. It can be used on hardware and sinks and handrails and chair arm rails and tabletops and even walls. And there's been a lot of clinical studies about copper, and this is one that was done with the Cuvero product. And I think, the numbers in the bottom part of this graphic are pretty telling that, copper is, keeps 88% of hospital rooms clean as opposed to traditional surfaces. And 93% with copper maintain the clean as opposed to those with traditional surfaces. So there's a good argument for this. And I think there's been some issues with how copper looks and obviously the cost, but I think that the products have evolved, and it's making the ROI, it's making the business case for using a product like this, because the investing up front will definitely pay off in the future. Another product similar to copper in terms of its ability to it's easily cleanable. It's a non-glass. This is glass, and it's non-porous surface. And so it makes it difficult for germs and bacteria to adhere to. And it can be easily cleaned and disinfected with bleach or common cleaning products. And it's also a sustainable and a natural material, which is even better. And this is actually from a CEU that's offered by Skyline Design that was developed by Kama, and Rosalind Kama and her colleagues. And it's there's a lot of great information in this CEU about the benefits of glass, and not only from an infection control standpoint, but for some other ways as well. And I think it's a great alternative to cubicle curtains. Not that I'm, trying to put down the cubicle curtain industry, but cubicle curtains, unless they're frequently changed or cleaned, harbor a lot of bacteria, and even those measures can't always reduce contamination. So this is something that I think healthcare and hospital administrators are going to look more closely at, because they're such a staple in hospitals, and they're cheaper initially to purchase and install than something like glass. Again, it's just a matter of weighing the decisions against the budget and the ultimate outcome and goal. And here's a product that's pretty cool that I came across recently. It's called Creon, and it's a solid surface material. Well, the Creon EcoActive version of this is a solid surface material that has this new technology that incorporates a series of activators into the product. I think it's like a photosynthesis type of technology. I'm not exactly clear on it, but when in contact with any type of light, it's able to purify the air, expel harmful bacteria, and basically clean itself. And so then by cleaning itself, it eliminates the use of harmful chemicals. So this has all kinds of uses in healthcare facilities and any type of facility as far as that's concerned. I think another thing is that we need to start, the design community needs to start thinking, and healthcare community needs to think about designing better spaces for telemedicine. The COVID-19 pandemic has brought telemedicine into a new light, because as medical professionals need to stay healthy and disease-free, the need for remote technologies has skyrocketed. And so both the Centers for Disease Control and the World Health Organization are advocating for telemedicine to monitor patients and reduce risks of them spreading the virus by traveling to hospitals. But, I think part of the issue with this is not all institutions have the equipment to deliver remote consultations and allocate the required staff and resources. They don't have dedicated spaces for telemedicine, which causes privacy issue and also may affect staff performance if they don't have a space that adequately supports the function that they need to do. And telemedicine is another area where I think modular spaces would work quite well. These pods that were shown at Steelcase Health at NeoCon last year at the Merchandise Mart in Chicago were quick to install. They're quick to install modular spaces that can act as freestanding meeting rooms that provide a high degree of privacy, and also they look nice and they feel nice. So none of what I'm saying really is rocket science. It's about refocusing on the things that can make our healthcare facilities better prepared to serve patients and staff in the next pandemic. And I think it's really time for the healthcare design industry to embrace some of these new and emerging ideas that are just starting to take hold, just like what Sheila said, and reinvigorate best practices. Excuse me again. But here's the other problem. Who's going to pay for it? Often the best design ideas don't fall within the budget, or they get value engineered out. And it may not be realistic to expect hospitals and health systems to be able to afford facility upgrades. I mean, there's going to be a lot of financial fallout from COVID-19. And here's a quote from Cindy McCullough at HDR recently in Modern Healthcare that, budgets don't include surge planning, for instance, or many of the other things I just talked about, upgraded materials and telemedicine spaces and so forth. And in this same article in Modern Healthcare, they estimated that it costs around $150,000 to build each new hospital room or renovate existing ones for multiple purposes. So if we're just talking about, surge capacity, let's say, it's $150,000 per room. So then they estimated at Modern Healthcare, a third of our nation's hospital capacity could be modernized with $40 billion grant and loan program from the government. $40 billion. Tack on a little bit more, and hospitals could pay for other things like automation and upgraded surface materials. Now, $40 billion is a small fraction of the $30 trillion stimulus package that was passed a few weeks ago by the US government. So I think this is something that our government seriously needs to look at, and I hope they do, because there's precedent for this type of funding. In November 1945, President Harry Truman delivered a special message to Congress in which he outlined a 5-part program for improving the health and health care of Americans. And the Hill-Burton Act, which was passed the following year, responded to the first of the president's proposals. It called for the construction of hospitals and related healthcare facilities, providing federal grants and guaranteed loans to improve America's hospital system. And, by 1975, Hill-Burton had been responsible for the construction of nearly 1/3 of U.S. hospitals, including many in the 40% of U.S. counties that lacked hospitals in 1945. So this was a huge, huge game changer in the healthcare industry, and it was a facility program. And, Hill-Burton was also responsible for a lot of the spending that was spent in the last 20 years because all those Hill-Burton hospitals were old. They needed to be replaced. They needed to be renovated. So it was a huge thing that changed the trajectory of the healthcare facilities planning and design and construction industry. And I think the government could step in, the US government could step in again and take a role in this. So that's my presentation. There's certainly a lot of other things that we could talk about where this is concerned. One thing that I didn't bring up is I think, besides pandemic planning, infection control and so forth is really important to prevent the spread of hospital-acquired infections, which, by the way, kill 72,000 Americans each year. So to me, that the impact of that is much more, than a coronavirus, because the coronavirus hopefully will go away. We'll find a treatment for it, and it will go away. But hospital-acquired infections are not going to go away. So I think that's a conversation for another day. But if you have any questions or any comments on any of this, I would love to hear what you think. So please email me at saramarberry.com. Sara@saramarberry.com. So thank you for listening if you made it all the way to the end here. And again, if you want to email me, that's my email address. Please follow my blog if you want, and or connect with me on LinkedIn or follow me on Twitter. And the references that I use to inform this presentation are listed here at the end of this end of my slideshow. So thank you for listening.